Hello, everybody. Thank you for being here. This is the last event for the Queer Health Education Series that Bradbury-Sullivan LGBT Community Center is putting on for the month of April. My name is Jordan Sanchez. My pronouns are they, she, and I'm a healthcare enrollment coordinator for Pittsburgh and Western Pennsylvania.
And I am Owen Pudliner. I use he, him pronouns, and I am the healthcare coordinator for Allentown and an Eastern PA region.
And my name is David Chelly, and I'm the healthcare enrollment coordinator for the greater Philadelphia area.
Okay, so thank you all for being here. Today is a very important topic, especially as we are healthcare advocates, LGBTQIA+ advocates, and people that may populate the community. We're talking about trans health, and we wanted to start the event by discussing that sex and gender are not binary. They're often used as interchangeable terms, and while there might be some overlap, it's important to distinguish the two of them as their own separate terms, and that they are in fact non-binary. They're non-binary. So this topic just within itself, this discussion is very complex, it's very deep, and there's a lot to discuss. So we're just gonna scratch the surface with just this quick slide. So I wanted to discuss some terminology. Sex, it looks at the reproductive structure and functions of species like humans, humans like us, cats, animals, any species. That's just what the term sex means, and that's a very simplified term. But just something to keep in mind, especially as we think about gender, which we've defined as a classification system that characterizes people's traits, characteristics based on their sex. And then gender identity can describe how a person's relationship to gender and how they express or present their gender. But again, this is all categorized in a binary understanding, right? So we've been taught that the biological sex categories are only male or female, that gender is only man or woman, and that those two influence each other. So when a child is born, they might be assigned male at birth, so then they're given the gender identity of a boy, they grow into a man, and there's not a lot of room for flexibility or even queerness within that, right? So something to distinguish here is that this is all based on this is how we, a Western society, have built our understanding of sex and gender, but that is a social construction, right? So with it being a social construction, there leaves us rooms to reconstruct it to be more inclusive to intersex people, to trans people, to non-binary people, to genderqueer people, or even cisgender people who want to be more expressive, more playful, more fluid within their gender expression. So I'm going to pass it over to David, who's going to discuss some health disparities. Oops.
Yeah, thank you, Jordan. So on the screen, there's going to be some statistics that I'm going to go through, but I really loved what Jordan was talking about. It really hits home, especially as like a cisgender person. I really believe it's important to not only advocate for the transgender and non-binary community, but to be actively vocally supportive, as well as show up physically in spaces. I believe that we should put their names at the forefront, and that it's really about putting their voices to the front and not taking any of the spotlight away. So some health disparities that we're going to go through are that 28% of transgender individuals, including 22% of transgender people of color, report postponing or not receiving necessary medical care for fear of discrimination in the year prior. That's kind of insane, thinking about just in general not going back to the doctors in general because of a remark that a professional in the medical field gave to you. The next one is 2 in 3 transgender individuals have experienced some form of discrimination in the year prior, including 65% of transgender people of color. And then with the final statistic being 46% of transgender individuals have had health insurance deny them of gender affirming care in the last year prior. So with these statistics and everything going on the news, especially in Texas with Governor Abbott, and in Arizona with the governor not even recognizing that transgender people exist in general, which is just like insane. Like it goes to show the vastness of how trans people, and especially those in the BIPOC community, are like discriminated against. So with that, I'm going to pass it off to Owen to go over his personal story.
Thanks, David. Jordan, since we have 2 people now, if you want to put up the Padlet while I talk and see if people want to contribute to it, they can.
Okay.
I don't mind. Just since I don't really have a slide for what I'm going to talk about. So with that said, the topic today, trans health, that's admittedly like incredibly broad. We're anticipating that we touch on a lot of the foundations of what trans healthcare looks like, especially when I pass it over to Dane in a few minutes. He is the expert, so I'm going to let him speak to that actual portion. Jordan and David shared their knowledge about gender identity and the binary system that we're beholden to, and how that leads to the health disparities that trans folks encounter. Now, as a trans man myself, living my best life, I'm hoping to engage with you all by sharing some small pieces of my life, as well as some useful words for folks who are navigating their health. In my experience and my perspective, I have seen that the process of finding resources that are helpful and affirming towards trans and non-binary folks, it's kind of an exercise in teamwork. It's community building and sharing, even if we're miles apart. We often congregate in online communities to commiserate and to celebrate, to share our good and our bad experiences, and to support and guide each other through their journeys. Over the years, I've seen so many people in the community show up for each other in different spaces like subreddits, Facebook groups, specific forums that are owned and operated by trans folks. And as more folks are connected to community centers like ours, Bradbury-Sullivan, it's still a collaborative effort, however, kind of at a different scale. When things are operating smoothly, I should say, the amount of labor each individual has to do is way less, and we can focus on the more exciting aspects of our community. We can celebrate and create culture together. With that said, it's kind of a double-edged sword with the fact that we resource pool. There's a portion of our community that is really vigorous about vetting and spreading information about their experiences in healthcare. I've seen a lot of folks in online communities who do healthcare navigation and advocacy as their full-time job, and then continue doing that in their off time in these communities. And I've seen folks who just have time and passion to learn and pass on the information just because they would have loved for someone to do that for them. And that's something that I really love to see, and I can relate. I've definitely participated in these communities myself in that manner. And if I can be a resource and get someone the care they need quicker, I'm happy to share my knowledge and help my siblings in the trans community. But as I said, it's double-edged sword. The other side to that is some people aren't within range of these vetted places. And there's also just folks who want to get through their daily lives without having to educate medical providers and staff. Now that I'm here at Bradbury-Sullivan Center in the Lehigh Valley, I'm directly seeing that there are more and more local resources, more providers that are closer to home in the Lehigh Valley. But speaking for Pennsylvania, it's not a universal experience. I've lived in the Lehigh Valley my whole life, and I've seen, as I'm just getting older, seen more and more of the state, and I'm seeing how vastly different the parts of the states are. Like, for example, folks in Philly, there's areas where you see a rainbow flag no matter which way you're looking. And then there's areas much less populated in Pennsylvania where if you see a flag, it's probably attached to a truck and it's not fun and vibrant. And I'll leave it there. Now, as far as navigating the medical arena, I have two personal stories that I'd like to share, and they kind of exemplify some areas of concern, highlighting different ways that I think the medical community can impact trans folks. One, many years ago, returning to my family doctor after transition was really eye-opening for me. This was the doctor that I had gone to all my annuals and my sick visits as a child, like my entire life. And I guess I should have seen the signs growing up as a child. When I would go there, they'd make those little remarks about, oh, my tomboyishness, stuff like that. But the repression of my identity did not leave me very open for reflection about other people's behaviors. So I went back to this doctor, not really sure how it would go as a trans person, but feeling nervous enough to ask my partner to make the appointment for me. And never have I ever felt more like a science experiment than that 10-minute doctor appointment. While I was not turned away for being trans, I'll give them that. I did receive the care that I needed. But multiple doctors were pulled into this office and I just felt completely dehumanized. They were literally like gawking at my body. And just to say the impact of that experience, I really avoided doctors for a long time after that, other than the known safe space of the Mazzoni Center at the time, where I had an affirming provider. I received my HRT continuing care. It's just a short drive 2 hours away from me. That was the only doctor I would go to. Now, much more recently, this past summer, in fact, after many years of being on the appropriate hormones for my body, and having all my records changed to reflect my name and my gender identity, I'm feeling confident and comfortable in my body. I visited the hospital to have some imaging done, and checking in with the receptionist. She was asking me all the requisite questions that you get asked before imaging, in the time of COVID even. So do you have any COVID symptoms? Did you fast this morning, etc. Towards the end of this line of questioning, she completely freezes up. She is clicking all over her large monitor, and muttering to herself, things like, I've never seen this before. So imagine standing in front of someone doing that, and only that for a solid minute. It's a very long minute. Eventually her coworker steps in to help her, and says, click on demographics. And I could see it all wash over her, and it also washed over me, and I realized what happened. She realized that I'm a trans man. So she finally said, is there any possibility that you're pregnant? And, I laughed and I was like, no. But anyway, this is just a really interesting example of the other end of this, about just not being seen and not being educated that, trans men exist. And, I might have a beard, but I still have body parts that you have to ask about. And I want to say that I now have one like weird inside joke with myself, which is how many receptionists does it take to check in a trans man? And anyway, with all that said, this is where I'd like to share the concept of harm reduction approach to self-advocacy. In a few words, this is self-advocating in the moment if you're able. I think this might be useful for those who are going to new doctors, and especially useful if you need to see specialists where you might not have quite as much of a selection with who you can see. The first thing to note with this approach is that you should trust yourself to do what's right for you. Whether that is speaking up or just rolling with the punches for your own sense of safety, what's right for you is right for you, and your choice is valid here. If you decide to prioritize your safety, again, some days you don't have the mental or emotional bandwidth to deal with training someone in the moment. And I've been there, and I just want to reassure folks they don't get into like a shame spiral. And that happens because it's totally valid to let things be sometimes. But if you are able to speak up for yourself in the moment when you are having an interaction with a medical provider or anyone really who's not treating you in an affirming manner, maybe they use really uncomfortable language, there's kind of a process that I'm going to go through right here. First, when this happens, and it might be hard, don't interrupt. Interruption typically stirs like a sense of being put on defense right out of the gate. And then two, begin by giving the medical provider a statement of appreciation. Thanks for taking the time to explain that to me. Three, explain why, and this is important, why they said what it was inaccurate, inappropriate, or offensive. For example, you could say, in my example, as a trans man, it's really important to me that you always use inclusive language when we're communicating. A lot of painful memories come up when you refer to my body as a woman's body, which makes it harder for me to trust you and continue working with you. Four, give them your expectations moving forward. And that would be something like, when I come in for my next appointment, my hope is that you'll be able to use inclusive language the whole time. Do you think that will be possible? Five, this is very hard. Stand your ground. If they apologize or make excuses, they can claim they are working on it, but you are going to require them to be better. Offer them help to find someone. Like for us here at the center, we have a very rigorous training that we can refer folks to. But you're there as a patient, you're not there to make money. So it's not your job to provide any further resources. And then at the end of this, show appreciation again. I'm not an expert in psychology, but like the reward centers in our brain help us retain information. So a lot of times if you say thanks, that person will be more likely to be an ally and affirming in the future. That was a lot. With all that said, I'm going to pass the spotlight over to Dane in 1 second so that he can share his knowledge. I really want to express my gratitude for being able to have Dane here with us today. He's a wonderfully affirming provider of clinical care, and he was my original provider for gender affirming care for me personally, and really set the bar high for all providers I've seen since. Over to you, Dane.
Thanks, Owen. I appreciate it. That's a kind introduction. So I will go ahead and screen share, and we'll use some slides. Just a quick introduction, if I can get the slide to advance. We're good. There we go. So I'm a nurse practitioner who's been doing gender affirming and LGBTQ care in general for probably about 13 years at this point. I direct the LGBTQ services for Mainline Health, which is a large healthcare system sort of on the northwestern border of Philadelphia. I work collaboratively with lots of different providers for TransLine, which is a collaborative, it's sort of a hotline for providers around the country to ask questions about trans and non-binary people that they may be providing care to, and then do a good bit of work. I'm not really an activist, so I like to sort of stay behind the scenes to push change, and kind of inform leaders in the political agency or in the political arena to make laws that make sense for trans non-binary folks in the United States. So that's just a brief bit about me, not all that important. So I'm just going to kind of talk a little bit tonight with the idea that there will be some questions or some conversation at some point. If you have questions or you had them kind of coming into today's session, please feel free, actually, let me just put this in that mode. Please feel free to share, write down your questions so that you remember them. Listen to other people's experiences and remember that it's their experience and not necessarily yours to relate to or to dispel. And then it probably goes without saying, but we'll be respectful of everybody's opinions and what they share tonight. And by respectful, that means some confidentiality and not repeating things that people say in a way that would disclose their identity. So some of the things, the premise for what I'll talk about tonight is what should you be looking for in a provider, and how do you go about finding a provider or vetting a provider. So we all know there are things out there like ZocDoc, and there's Google, that you could just put in a provider's name, and see there's usually reviews on some site about them, and I think that could be helpful on some levels. I think I know there are some organizations that you can actually go on and do a search based on your geography for providers, and I'm happy to share those resources with anybody. But really, what I want you to know at this moment is, what is the provider looking for? So you have your sort of set of criteria in what you need from a visit, whether that be like, I have a fever and a sore throat and I need treatment for that, or whether that's I think I might like to start gender affirming hormones and I need a provider that can do that with me. But really, what I look for as a provider when someone comes in to see me for gender affirming hormones, I really am looking for their story, kind of as it relates to the information I just shared. I'm looking for your goals. It is your transition. It is not mine. My job is to set the perimeter and sort of boundaries of safety. And my job is to safely and effectively medically transition you, if I can use that as a verb. But those aren't goals. Those are sort of professional standards. So I want to know what your goals are. And I think it's a big red flag when you see a provider that doesn't ask you what your goals are, especially if they're experienced. They may sort of have this feeling that everything is binary and they're going to dose medications to make you from one thing to another thing, and that is not reflective of what everybody's looking for. Your provider should be asking about your timeline. Sometimes I've been doing this so long that sometimes I assume that when someone is in front of me that they want to start hormones now. Or why else would they be in front of me? And when I ask them about their timeline, often I'll get an answer of something like, well, I graduate college in about 9 months and I want to be able to pass as my affirmed gender when I start to apply for my new jobs. Or, my mother, a 40 or 50-year-old person, my mother just died. She was never supportive of who I am. And I feel like I'm ready now to get started on hormones. And this is the time for me. I am always asking patients about their support system. It doesn't mean that you have to have a fan club to support to take gender affirming hormones, but it really does. There needs to be somebody in your world, and for some people, depending on where they live in the country, that entire world is online. And I'm respectful of that, and that's an acceptable answer to me. But I can't be sort of your one and only source for accurate information. I'm not an expert on makeup and breast forms and hairstyles. Like, I'm just not. I can't be all of those things as a clinician. So I want to know who your people are, and then I sort of want to know what your knowledge is. When I'm in a visit with a new patient who's in to see me for gender affirming hormones, I go through a basic medical history. I mean, I need to know if you had your tonsils and appendix out, and I need to know if you take medication for heartburn. I need to know all of that basic medical information before we even really talk about the gender stuff. And then I really start by having people tell me their story, because in that story, I'm going to get an idea about their knowledge as it relates to their goals. I like to share this slide because I feel like consumers and patients, this is like a mystery to them, and it's not a mystery. We treat patients based on the diagnosis of gender dysphoria. Whether you like that as a diagnosis or not, that is how the medical system works. And that is what actually lets me get paid and gets all of your treatment paid for. Everything from your hormones to your labs to your surgery, to everything. It's under this diagnosis. When I first started doing this, we would do anything. We would code any diagnosis except this, because the last thing we wanted to do was tip anybody your insurance off, because that was just sort of this automatic denial. But it has completely been a 180 in that I actually need this diagnosis in your chart to get some things covered for you, especially when it comes to surgery. Down the road, this is the diagnosis you need to have. And it isn't a mystery about what this diagnosis consists of. So this is out of the DSM because it is a mental health diagnosis. 6 of the following associated things cause significant distress or impairment in function. And it has to have lasted for 6 months, at least 6 months. When you read down this list, you may have like a big moment of eye rolling, because this is a very stereotypical kind of circa 1950s list of things that describe gender roles. What I do with this is I use this as my guide in my conversation for your storytelling. So I am asking people, what are the things about your body as it is right now that feel the most disconnected for you? What are the things about your body that you dislike the most? I don't ask people what causes your dysphoria. I feel like I get a canned answer. I really want to know, what about your body is a problem? Part of what helps me with that question is I know there are some things that hormones will do and some things that hormones will not do. And if your biggest source of discomfort is the fact that you identify as male and you're 4'9", or you identify as female and you're 6'5", I can't change that. And it doesn't mean that, that we can't move forward, but it really helps with expectation setting when we're talking about what hormones can and can't do, and then the time frame in which they make those changes. I'm looking for sort of, what is your gender expression? Is your gender expression one that doesn't reflect your gender identity at all because it's not safe, or you would lose your job, or your parents would stop paying for college, or any of those things that keep any of us from not truly expressing our gender, our authentic self? But sometimes I sort of want to know, like, what are the things that you're doing, maybe just quietly, that make you feel affirmed in your gender identity? Do you wear underwear that, represent how you feel? Do you paint your toenails, in a way that makes you feel really good, but you can completely hide? What are the things that you do even subtly that make you feel good and express your affirmed gender? I like background questions and like long time ago stories. Often I get a patient who like wants to give me like the last 6 months of their narrative because it feels safest for them. But I really push people and say questions. I ask questions like, what kind of Halloween costumes did you used to use when you were a kid? Tell me about that. And I will ask, so when you were a kid, were you a typical boy? Were you a typical girl? Were you neither typical boy or girl? And what kind of house did you grow up in? Was there really strict gender roles in your house, that you sort of, that's kind of imprinted on you and maybe sort of made this something that you did later rather than sooner? So this is what I'm not going to go through all of them, but this is what gender dysphoria encompasses. I absolutely prescribe hormones for people that don't meet this criteria. I say that in my note. Patient does not meet the criteria for gender dysphoria. And then I'll just go on to talk about why we're moving forward with hormones anyway, because we can. It's not a law, it's a diagnosis. So let's hop in a little bit to medications, because I think people get a little narrow focused in hormones and how they work. So when we're talking about masculinizing regimens, obviously the masculinizing hormone is testosterone, and it does a great job of developing all the male secondary sex characteristics that we know about. But there are other medicines that are very, very useful and that I use often. There are aromatase inhibitors, and that's a category of medicine that blocks estrogen. We don't have to block estrogen for testosterone to be effective. It just sort of overtakes estrogen. But there are some people, especially non-binary folks, who really don't want full masculinization, not in 6 months and not in 6 years. So sometimes what we will wind up doing is using an aromatase inhibitor or an estrogen blocker to stop menstruation, stop chest development, and allow us to give very, very low doses of testosterone that make them feel good. Without it doesn't matter how low of a dose of testosterone you take, if you're on it for long enough, it will fully masculinize you. 5-alpha reductase inhibitors are medications like finasteride and dutasteride. They're fantastic for the prevention of hair loss. Nobody wants to lose their hair. So if testosterone is going to do that more for some people than for other people. I always tell patients, when I first started doing this, we gave everybody the same dose of testosterone across the board. It really didn't matter. As long as you were like above about the age of 17 or 18, you got this one dose of T, and everybody's hair fell out. We don't do that anymore. We're a little bit more selective, a little bit more careful. And we have learned that you can give much, much lower doses of testosterone and masculinize people very, very effectively and prevent that from happening, or at least make it a little bit more of a natural process where maybe in 10 years it's going to happen as opposed to 12 months. And I don't ever discount the use of progesterone and estrogen for people. There are people that are male identified that have the capacity to become pregnant and they don't want to become pregnant. I'm a firm believer that anyone who doesn't want to be pregnant should not be pregnant. And I do use oral contraceptives with people. I certainly insert IUDs for people. And those hormones are very, very effective in masculinized people. When we look at feminizing regimens, obviously estrogen is the medicine that feminizes, and it does a great job of that. But estrogen in a boxing ring with testosterone doesn't win. So we do need to block testosterone for kind of maximal effect of estrogen. Estrogen is also, I'll say the word dangerous, but I don't want it to be overblown. It has the potential to create more life-threatening adverse effects, specifically blood clots. So we really can't give very high doses of estrogen that would overcome testosterone. We can't do that safely. So we block testosterone to be able to keep estrogen doses in a safe range. Spironolactone and bicalutamide are two different blockers that I've used. They're both effective. They're both safe. I kind of use them interchangeably. Spironolactone is kind of the gold standard that everybody uses, not always well tolerated by everybody. So I use bicalutamide at times. Progesterone is a great drug. I think it's really underutilized. Progesterone does a really nice job of suppressing testosterone. So if I have someone who doesn't want to be on a blocker, they just want to be on estradiol, that's great. I'll add progesterone into the regimen. And not only does it sort of help them sustain their sex drive, but it also sort of suppresses that testosterone. And then the 5-alpha reductase inhibitors, so we use them in trans men for prevention of hair loss. In feminizing regimens, these drugs are great at slowing down facial hair growth. And when we give them to trans men, that happens too. So I can't give these to trans men who haven't formed any facial hair yet, unless it's a non-binary person who doesn't want facial hair. And then I do use those medications because they're effective. But for trans women, I use it to slow down facial hair. It makes it a lot easier to manage. And I do use testosterone in feminizing people. If somebody does not have testicles anymore, they have no inside source of testosterone, you need testosterone. Every biological creature that has sex hormones has testosterone. It is the only hormone that is responsible for libido. It is a major energy producer. And it's a major metabolism supporter. So I have believed for a long time that not giving testosterone to somebody post-orchiectomy or post-vaginoplasty is really just almost like negligence. You have to replace somebody's testosterone. Obviously we don't use masculinizing doses, but at the appropriate doses with the appropriate medications, the delivery methods, it's an important medicine. So just two different charts I have to sort of what you can expect from different regimens and kind of a timeline. And I think this is helpful for people that are maybe seeing a provider that isn't so experienced, or that the patient may know more than the provider. So you can sort of keep this, you're welcome to screenshot anything, but you sort of, this is what you should be expecting from whatever regimen somebody puts you on with feminizing medicines. 0 to 4 months, I expect a decrease in libido, softer skin, slower hair growth, nipple sensitivity and breast budding. I expect to see a shifting in emotional expression, and I expect your odor to change. Testosterone makes people smell very different than no testosterone. Once we get sort of that 4 to 12 month mark, I do expect to see decreased sperm production. I expect to see fewer spontaneous erections, if any. Thickening of hair on your head happens with estrogen. It's wonderful for hair and skin. And I expect to see less muscle mass. The two things in red here are the things that are irreversible if someone takes blockers and hormones, for a reasonable and long enough amount of time that these things happen. They are permanent if you would stop taking hormones and blockers. 1 to 5 years is a long time frame, but it isn't when you think about this in context of puberty. That's kind of how long puberty happens, right? For people, it sort of starts when you're, 10, 11 years old and goes, maybe till you're 20, but definitely for about 5 years. I expect to see breast maturity, and that's a change in the shape of the breast that forms. I expect to see shape change, as in fat redistribution. One of the things that those assigned male at birth really need in feminizing regimens is a shift in the shape of their body. They need curves. And that really takes a long time. It's years. However, what they experience that is very helpful is once we get that muscle mass down, and that happens pretty early, their shape looks different. They're less broad up in their upper body. So they don't necessarily have curves yet, but they don't look thick in their upper body like they might with testosterone. Estrogen and blockers slow down people's metabolism, so they do gain weight. And genitals will atrophy. The penis becomes smaller and the scrotum becomes smaller as the testicles atrophy. So from masculinizing hormones, you'll notice there's more in red here. Testosterone does have more non-reversible effects. That early stage of testosterone, I always tell people there's going to be a lot happening for you, but the world really isn't going to know it. But you are. There's an increase in appetite, an increase in sex drive, an increase in sweating and kind of oiliness. There will be thicker hair on your body where you already have hair. So lower legs, lower arms, groin region, armpits. There's an emotional shift that happens with testosterone. I do expect periods to stop by about 3 months. Sometimes it takes a little bit longer. And sometimes with very low doses of testosterone, it doesn't stop at all. And again, that odor change is significant. People notice that. 4 to 12 months, we're seeing new body hair start to form. We're starting to hear some changes in people's voices by about 4 or 6 months. It usually starts out as a hoarseness, and some people get a sore throat as the voice is starting to change. The full thickening and shortening of the vocal cords is about 2 years away, but we see pretty significant changes by about 6 months. Bottom growth, something that we're aware of. The clitoris is an erectile organ. It responds to androgens and to arousal, so it will grow. I have no idea how much growth someone is going to get. It's very much genetically determined, and it depends on how large the clitoris is now before testosterone. We see an increase in strength and muscle mass, some coarsening of the skin, and then usually we start to see acne around the 12-month mark. Most people will start to develop facial hair around the 1 year mark. There are always outliers. Some people get lots of facial hair at 6 months, and some people don't get a whisker for 3 years. There's no way for me to predict that. But most people fall in with like a upper lip kind of hair and chin strappy kind of stuff around the 1 year mark. 1 to 5 years, we're looking at new hair growth on the back, on the butt, on the belly, shape change. We've got muscle mass now, and now we are starting to see body fat redistribution to the abdomen. And then we see hair on the head start to change. We see sort of this recession of the frontal line, and we may see some crown balding in the back. I don't expect people's hair to fall out, but I do expect their hairline to change. That's kind of what makes you not look 12 for your whole life, is that you've got to have a little bit of a shift in that hairline, so you just don't look like an adolescent when you're 35 years old. So these are some things that I get asked most often, and I can ask and answer the questions, or I can stop talking and see if there's any questions. But I get asked a lot about microdosing. I think that that's something that's a catchphrase that's been out there for a couple of years now. I don't like the phrase because there's no such thing as macrodosing. What I gather when somebody says to me, I'm interested in microdosing, what I gather from that, and I always ask for clarification, what I'm hearing them say is I want a low dose of hormones because I'm not sure I want full masculinization or feminization, or I'm not feeling like I am ready to move into a dose of medication that's going to make changes for me that I'm not ready for in my world, as in my parents don't know, or I'm not safe at work, or my children don't know, and that kind of thing. So I don't like the phrase microdosing. I know what it means, but I always ask for clarification about it. I'm asked a lot about fertility preservation and what that looks like for people. I'm often asked about what happens if I stop taking hormones and blockers. And I think that's a legitimate question. I have no problems when people ask me that. I have a little bit of I don't want to say a problem. I get a little concerned when someone says to me, what happens if I want to stop after a couple months? That's just a bit of a flag for me that says, well, what are we looking for then? Because I just went through a list of things that happened with you and when, and what exactly are we looking for at 2 or 3 months? Or what are we looking to avoid happening? Like, what is it that you need not to happen that you're asking me if you could stop very soon after starting? How often do I look at labs, and how often do visits happen? And then I'm always asked, do I need a therapist? You don't need a therapist. No provider should tell you you need a therapist. You do not, by guidelines and recommendations, need a letter of support for gender affirming hormone prescription. You just don't. There is nowhere that recommends that. You do need letters of support for surgery. That is, even with the new WPATH standards coming out, I don't think that's going away. I'm hoping that we'll get rid of 2 letters for genital surgery as a requirement, but I don't see letters of support going away. And honestly, that's mostly because the surgeons don't know you. They get to meet with you for a consult and then maybe a second or third consult before your surgery. So what, they've spent like 45 minutes with you before you're unconscious on the OR table. Like they need to hear from somebody that has spent a lot more time from you or with you. And I don't think that's a terrible thing. I do think sometimes it's a financial hardship for people though. Fortunately, there's some decent options out there. And fortunately, most of these programs and most surgeons at this point can refer people to therapists that when you go and say to them, I'm here because I need a letter of support for my surgery, they're respectful of that. You know, they know you're not staying in therapy with them indefinitely. They know exactly what the goal is. They have experience with that. They know how to get the information that they need to write the letter that they need to read, they need to write, and it usually goes pretty smoothly. I say all of that from the privileged position of the Northeast part of the country, but I don't think the same is true if somebody lives in Kentucky. I think that was sort of where I wanted to stop with content. I wasn't sure how many questions there would be or kind of what the landscape would look like. I can keep talking, but I don't want to if there's things that people needed to know specifically.
I was interested in the second question of like, what happens if I stop taking HRT?
So all of the things that changed that are not permanent would reverse. So I guess it depends on who we're talking about. But if it's a masculinizing regimen within that first 3 months, there's not a lot that changes physically. Your sex drive will go up and then it will kind of go back down. Your appetite will go up and then it will go back down. Your body odor will change and then it will change back. You will become kind of hotter and sweatier, and then that will kind of go away. In 2 or 3 months on a masculinizing regimen, I really can, maybe you'll get a little bit more hair where you have it, or a little coarser hair on like your lower legs or lower arms, but not much is going to happen. And similar with feminizing regimens, estrogen and blockers, you'll probably have a lower libido, but that would reverse. You'll probably get less erections, but that would reverse. You'll probably get an increase in your ability to cry, and then that would kind of dissipate if you stopped. So there's not a whole lot that really happens that soon. It's in the context of puberty. 2 or 3 months on hormones is kind of like an 11-year-old. There's some things that are changing about them, but not much. They look a little different. They're acting a little different. Their emotional ability is a little bit different. But most 11-year-olds don't have facial hair. Most 11-year-olds don't have fully developed breasts. So that's sort of the analogy that I try to give people with what they can expect.
So if someone was like in a longer time frame of their therapy and they're like, I don't want to do this anymore, maybe this doesn't fit who I am anymore, there are some cases where some parts of their body that is irreversible, like you said. So how do you just navigate that in general as like a healthcare provider or a practitioner?
How do I navigate the question, or how do I navigate it when it happens?
I guess both. Like if there was a hypothetical of like, I want to do this for like 5 years, then maybe not, or in case there was an instance that did happen to you.
So I don't think this is what you're asking me, and I'll sort of be a little bit more direct, but I think you've opened a good door to talk about people that change their mind or desisters. 60 Minutes did a piece on this, like maybe 6 or 8 months ago, that made me crazy. That we talk about people that change their mind or got started on hormones before they were really ready, and I want to say that is such an incredibly small number of people, so small. I would say that in the 10,000 or so transgender patients that I've seen over the last decade and a bit, I've had 3 people stop taking hormones and blockers. And I would like to think that that's true because I and the team that I've worked with in different places are good enough at getting people the resources and supports that they need to make the decision that's right for them. Almost always when someone sees me and we're talking about the possibility of hormones, what's really behind their decision making is that it's not that they don't want hormones, it's that it's just not yet. There's something that needs to get worked out for them. It's usually not even about them. It's usually about like, my parents are going to stop paying for college if I start taking, like it's usually, or my wife or husband is going to leave me. It's almost not about them at all. But I think it's important to make sure that when we're talking about people that change their mind, we talk about why, what happened. Was this because they developed all the things that they wanted and they were good? Maybe. But more often than not, it's because something went wrong for them in their life that they need to put this on pause and take care of life and then come back to it. And I see that a lot. I don't see it very much with young people, but I see it in people that look to start to their transition in their 40s and 50s. I see it a good bit. So it's more directly to the question I think you were asking. I just talk to people about what their goals are. What do you want? Because if you want a really deep voice and facial hair, but you don't really want, bottom growth or, you don't want like muscle mass, we are going to have to talk about whether that's a reasonable expectation because of the order of things that happen.
Right.
So it's a lot about, expectation setting for people. I have found that most people, even when they have something very specific in mind that they want or don't want, are once they're presented with kind of like this is what I expect to happen and when, they're better able to be like, okay, so I kind of can't get what I want. I can't get facial hair without getting body hair first. And they spend some time with that and they sit with that and they think about ways that they can navigate that. And most people proceed. It doesn't usually deter most people. I also think that people don't always get the right information before they get in front of me. And finally, when they're able to get the right information, they're like, oh, okay, so that's what this really is. I'm like, yes, that's what this really is. This is what bottom growth really is. This is what it means to stop making sperm. This is how this will impact you in the future. So I think in that sense, it really makes a difference to have somebody that just has experience doing this and having seen, some large number of people's transitions to say, in my experience, this is sort of how this goes.
Yeah. Okay. Thank you. I appreciate that.
Yeah, I just had I think it is a worthwhile story to share. I had a young assigned female at birth person. They were maybe 20, 21. Non-binary identity, really felt good in like an androgynous non-binary gender expression, and had some very, very definitive things that they wanted. They really wanted a deeper voice, and their voice was quite high. And they wanted kind of like a shape change. They wanted that redistribution and muscle mass. But they were adamant that they were going to stop taking hormones in 3 to 4 months. Like they must have said it 3 or 4 times. And at the end of the visit, I had said to them, I am not comfortable starting gender affirming hormones with you, given what your goals are and how different those goals are from what I am anticipating and expecting to happen with testosterone. And I think that was a very hard visit for me. And I think it was a very disappointing visit for them. I kept the door open. I invited them back. I told them I'm happy to talk to their therapist and help guide the therapist to to guide them in their sessions to think through some of this. But sometimes it's just not the right time for people to start hormones. It's rare. By the time they get to me, it's almost always the right time. But sometimes people just have a little more work to do.
Yeah, I see that. That makes sense. So I guess another question I have is if you run blood panels or anything beforehand, what do you look for so you ensure that like, okay, this is, we're gonna affirm their a person's gender in this way, but I want to make sure that like we're doing it in a safe way that isn't going to cause any unanticipated or unwanted health effects.
Yep, it's a good question. Before the pandemic, I always drew labs pre-hormones, masculinizing or feminizing, I always drew labs. And then COVID hit and no one was going to the lab and I was doing all telehealth. So I'm prescribing hormones without these baseline labs. And I have not started to draw baseline labs since that time. What I learned is in young, healthy adults, there is absolutely nothing to see. And I'm drawing labs that are normal for no reason at all. If you are assigned female at birth, your testosterone level is going to be under 100, unless there is something about you physically presenting to me that makes me think there's something else happening. Or if you are a 45 or a 50-year-old person, and I really am worried about your cholesterol, I will draw labs before. Or if you are somebody assigned female at birth who has heavy or irregular periods, and I'm worried that there's some anemia, then I will certainly take a look at labs before. But I don't draw labs pre-hormones anymore in otherwise young, healthy people with nothing else for me to see. I'm a primary care provider, so it's my job to look for sort of routine things as they may be abnormal. Like, are you presenting with symptoms of somebody who has a thyroiditis or some kind of a thyroid condition? I need to look at that, whether or not we're going to do hormones. I need to take a look at that. Same like with cholesterol, same with diabetes screening. You know, you tell me both your parents have diabetes and I see your body mass index indicates that you're at risk for that. I may want to check your blood sugar, but that's more in a primary care role than it is in a, I can't prescribe hormones for you if you become, you know, if I find out you have diabetes, I want to treat your diabetes. But we'll still, you know, we're still moving forward with hormones. There are so few things that there are so few absolute contraindications to hormones, and even fewer that I would see in routine labs, that it just doesn't make a lot of sense to do it as a matter of routine. I always check labs 3 months after you start any hormone or blocker, and 3 months after any change is made. So for most of my patients, hormones and blockers start, I see back 3 months, checking in with them, seeing how things are going, checking labs, usually checking labs again at 6 months, sometimes at 9 months, but almost always at the 1 year mark. And if we haven't made any changes, then I don't check their labs again for a year. There's just nothing for me to see. There's really I don't base my clinical changes on numbers unless there's some outrageously high, unsafe thing happening in your labs. But if that's the case, it's almost always because you misunderstood the injection instructions and you're injecting more or less, or somebody swapped out your syringe and you didn't realize that you now doubled your own dose. And, we've got these sky high numbers. It doesn't happen often. But I base my changes and my recommendations of medicine changes based on how things are going. I already told you, this is your transition, not mine. So if everything is safe, then I need to look at efficacy. And if things are going great and you feel really good about the changes that are happening, I have plenty of transgender women whose testosterone levels are higher than I like to see, but they feel great. And they really like using their penis and they don't mind having a sex drive and they're feminizing beautifully. And I don't do anything. You treat people, not numbers. The numbers are really just kind of this, like I said, set that perimeter of care.
Thank you. I really like how you put the quote with numbers. I really like that.
That's kind of I think people in medicine kind of forget that in general. Like, when it comes to body masses and body shape and things like that, like, if your body mass is really high and your weight is higher than what some scale says it should be, but you don't have high blood pressure, you don't have diabetes, and you don't have joint problems, and you feel really good, and all right, we'll see you next year. We'll check it all again next year.
Yeah, it's a nice way to humanize the situation.
Yeah.
Okay, so we just wanted to share a couple resources that are local to our respective areas. Okay, so for me, being in Pittsburgh and Western Pennsylvania, I always recommend folks to Sisters PJH. They are a Black and trans-led nonprofit organization that serves the QDPOC, or the queer, trans, Black, Indigenous people of color, trans and non-binary people within Southwestern Pennsylvania. They do a lot of great work, and they're hosting their annual People's Prides of Swissvale, I believe is what it's called, this summer. A lot of great work, a lot of work with housing, finding affirming care, just finding support in general in our area. Yeah, so I always recommend that organization. And then Owen and David have a couple they would like to share as well.
Yeah, I wanted to highlight the work that Eastern PA Trans Equity Project does. They do a lot of cool things. They might not have a physical center like we do, but they're still able to share a lot of resources. They do stuff like scholarships for transgender folk. They do micro grants, and they do like name change and gender marker assistance. They even, something that I just learned about very recently is that they actually have volunteers who try to escort folks to the courts when they need their name change. And in certain counties in Pennsylvania, I'm sure that's a lot more important than others. So that's just really wonderful. So connect with them if you're in the Eastern PA.
Yeah, and here in Philadelphia, Delay is a queer, trans, BIPOC, radical social justice organization. They have youth programs and transgender, non-conforming intersex programs as well, and a bunch of social services for testing, HIV testing, and references as well for the Philadelphia area. So yeah, definitely check them out.